Hello, this is Dr. Grande. Welcome to my video on clinical interviewing and counseling. I'm going to start by talking about assessment and counseling in general, and then narrow the discussion to clinical interviewing specifically. So let's take a look at assessment and counseling. Assessment is a systematic procedure for collecting data regarding a potential or current client. There are several components to assessment and counseling. The purpose of assessment actually involves a few different components. The first is building rapport with a potential or current client. So during the course of an assessment, particularly the clinical interviewing component, it's not unusual to develop a relationship with that client, develop a rapport. And this helps the client with adjustment to the particular agency or to the particular counselor. Now, a word of caution, sometimes the individual who performs assessments at any given agency is different than the individual who provides counseling. Now, it's okay to still build a rapport with that client, but the client should be reminded that the therapeutic relationship, the primary therapeutic relationship they'll be developing, will be with their counselor. And it's typical for the individual performing the assessment to indicate who that counselor is to the client, and sometimes even if there's an opportunity to take the client over to that counselor and introduce the two. Another component is screening for appropriateness for agency or referral. So again, depending on how an agency is structured, the individual who performs the assessment may also be screening that client to see if that client is appropriate for the services that the agency has to offer, or if that client needs to be referred to another agency. Another possibility is that the client is appropriate for the agency and referrals for other types of treatment will still be provided. So a good example of that is a mental health agency is treating somebody who is homeless. While they would provide the mental health treatment for that individual if that treatment is indicated, they certainly don't provide housing, but they can refer that individual to an agency that does provide housing. Another component is orienting the client to agency policy. I put here as needed and appropriate. So again, depending on the different procedures followed by an agency, the individual performing a clinical interview or any part of an assessment may have a responsibility to help orient the client to agency policy. Oftentimes this involves giving the client certain materials, making sure they understand them, or simply answering questions that the client has about the agency in general. For example, what are the qualifications of the counselors that work here? How is billing handled? The hours of operation of the agency, things of that nature. Then we have diagnosis. This is now according to DSM-5. So a diagnosis, of course, should only be given if one is indicated, but that is a central purpose of assessment. Then we have treatment planning. So this is laying out the treatment that the client will receive, or that you intend for that client to receive, and reviewing it with the client. Assessment can help improve client self-awareness. So as a client talks about all these different circumstances in their history and the history of their presenting problem, they may become more self-aware. So there is a therapeutic element in that sense to assessment. And then upon reassessment, there's an evaluation of treatment progress. So it's not unusual for many agencies to reassess clients every 6 months to every year. And typically these reassessments are not as thorough or comprehensive as the initial assessment. Rather, they're there to evaluate treatment progress and then make changes to treatment planning based on that evaluation. So there are three types of assessment I have listed here, and I'll be talking primarily about clinical interviewing. You have the clinical interviewing, you have instruments, right? So these are psychometric instruments that are given to the client. They're usually self-report, but not always. Some are administered by the clinician. And then observation. So this is what a counselor simply observes when they look at a client. Oftentimes observation is a part of both clinical interviewing and it is a part of some of the procedures used for administering instruments as well. So moving specifically to the area of clinical interviewing, there are three types of clinical interviews. There are structured interviews. So this is where the counselor has a list of dimensions and specific items and questions that they ask to the client. And deviation from this list of questions or items is rare and not typically expected. Then we have semi-structured, and this is a fairly popular type of clinical interview. This is where certain questions must be asked and certain dimensions must be covered, but there is freedom inside the interview structure for the clinician to go in different directions depending on what he or she deems as appropriate. And then we have unstructured. So unstructured interviews, these would typically be seen more in private practice settings and not in agency settings. But this would be really where the clinician, although they might have a list of dimensions in front of them, they're really structuring that interview specifically based on that client. And there aren't any questions that have to be asked, or they don't have to be asked in any particular order. Really, there's no questions at all. There's just sometimes these general dimensions. So let's take a look first at structured. So this is an example of one dimension of a structured interview. This particular one is parental history, which in some clinical interviews is listed under family history. So this is a very specific dimension in a highly structured document, structured interview. So you can see here that there isn't a lot of room for clinical judgment in this particular dimension. It's simply answering the questions and listing the information that's indicated. That's really it. It's highly structured. So moving now over to semi-structured, here's an example of a dimension in a semi-structured interview. So you can see that this would generally be called recreation, right? But it's also here, this particular dimension is social / community living / leisure. So it asks how somebody spends their day, what they do for fun, who is important in their life, and when they have a problem, who can they rely on for assistance. So there are specific questions. The clinician can ask these questions or versions of these questions, and then they answer in a narrative format. So that's a fairly good example of semi-structured. Then we have unstructured. So in unstructured, the clinician may have a list of possible categories, but the interview is unique to the client. And typically, in an unstructured interview, the clinician or counselor will still have an idea of what areas of history that they want to talk about. Now I put this here, but this does also apply to semi-structured and structured interviews. It's just in each one of these categories that I have listed here, like in a structured interview, for example, there would be several questions under each of these categories. In semi-structured, there may be a few questions, they may be more open-ended. But these areas of history are important to be touched upon in every interview, in my opinion. This is at a minimum. So you have childhood, developmental, mental health history, physical health history, family history, cultural background, substance use, gambling history, trauma history, legal history, employment or volunteer history, social, relational, romantic history, sexual history, military history, recreational or social history, spiritual and religious history, and suicide, self-harm, and aggression. At a minimum, these categories must be included in a clinical interview. However, there are other components of clinical interviews that some must be touched on, and some I'd strongly recommend. What must be touched on would be informed consent, and this would be at the beginning of a clinical interview. This is typically a document that's provided to you by an agency, but if you're in private practice, you're going to need to write your own informed consent. What's important in informed consent is that the client understands the nature of the relationship, the counseling relationship, including the services that are typically provided in counseling, some of the risks that are involved in counseling, and of course the limits to confidentiality. And typically there are other elements in informed consents as well, including rates, billing information, and that would be provided by your agency. The reason for referral. Again, this is toward the beginning of an interview, but it's important to understand why an individual was referred for counseling, and you could also expand that to if the client wants to sign any consents to release information, it would be important to collect information from other mental health care providers or physicians. The presenting problem. And again, this is toward the beginning of a clinical interview, and this would be simply asking the client what brought them in to counseling today, what they feel is going on. And there's a whole wide range of answers to those potential questions. Then we have goals. Now I feel this is a critical component of clinical interviewing, along with informed consent, the reason for referral, and the presenting problem. This is where you ask the client their goals in their own words, keeping in mind that those might not be the final goals that you and the client agree upon, but it's important to hear the client's perspective on what their goals are. Then you have symptom checklist and mental status exam. I feel these are critical components for clinical interviewing, but they're not a part of all clinical interviews. I certainly think that the mental status exam, in some way, shape, or form needs to make its way into a clinical interview. A symptom checklist, that could be debated, certainly. But I feel these two areas are pretty important. And if an agency doesn't have these two components in their interviewing document, in their biopsychosocial history document, you may want to gently investigate as to why, and if other resources like symptom checklist and a mental status exam are available, or perhaps they're conducted but at a different stage of the assessment process. But that's worth looking into. So I want to give you an example of a symptom checklist, and these come in many, many different varieties. This particular symptom checklist is relatively detailed, mostly because it has the symptom measured as being current and or in the last 30 days and or ever or never. So there's a lot of different possibilities for each item. So this covers a lot of different areas, and some of these areas if you were to endorse them, especially in terms the current area, in terms of the current area, would require some follow-up for sure. For example, dangerousness, suicide thought, suicide plan, self-mutilation, homicidal thoughts, or violent outburst. Any of those categories, I think, would require, in almost every case, immediate attention. And some other areas, it depend, like psychoses, auditory hallucinations or visual hallucinations, delusions, paranoia. It would really depend on the severity. So simply checking the box may not in itself mean there's a severe problem that needs to be dealt with immediately. However, oftentimes it probably would mean that reasonable and prudent attention needs to be paid to that particular dimension. The other area I mentioned, the clinical interview, I strongly recommend, that I believe is critical, is a mental status exam. There are many, many different types of mental status exams. I have an example coming up next of one, but there are many types available. You can find them on the internet. There are many free ones, and there's also versions that require payment. The mental status exam tries to capture a few different areas regarding client functioning and other areas, other characteristics of the client, including appearance, attitude and activity, mood, affect, speech and language, cognitions, as well as thought processes and content, client perception, and client insight and judgment. So here's an example of, I actually have 3 different slides. This mental status exam is fairly robust, so it took 3 slides to list all these components. But you see it pretty much matches what I discussed before. Here you have some appearance-oriented items, physical condition, motor behavior, speech quantity and quality. You have mood, affect, thought processes, content, hallucinations, and then some elements on memory, both recent and remote. And at the end here you see insight and judgment, they were the last 2 categories that I listed a few slides ago. This is one type, this is kind of a checklist system too for mental status exam, and many are like this, but as I mentioned, there are many types. Some involve short narratives, some involve simply checking off boxes as relevant. So then we have completing a clinical interview. So when all the history is collected, whether it's through structured, semi-structured, or unstructured interviews, and the mental status exam and the symptom checklist are complete, we want to look at wrapping up the clinical interview, and there's some elements that are really critical to have as part of the interview. The first here are the diagnostic impressions. Again, only if there are diagnostic impressions, and those of course would be found, the criteria for diagnoses would be found in the DSM-5. Next would be a case conceptualization. So this is where you describe the client's symptoms or issues or problems and try to put them into a conceptual framework in terms of what happened that led the client to where he or she is now. So you might include many different elements of the client's history, any type of genetic risk factors that may be apparent. For example, if a client's mother and father both abused alcohol, that's certainly a risk factor for developing alcohol use disorder. And it's not unusual in a case conceptualization to use a particular theoretical modality. For example, conceptualizing a case in terms of cognitive therapy beliefs, right? The cognitive behavioral therapy, So you may look at a client's cognitions and perceptions and intermediate beliefs and automatic thoughts and adaptive responses or lack thereof. And this helps you to formulate what happened in this client's life that brought on the symptoms and that maintains the symptoms. Then we have suicide and risk assessment, and this is critical. For every clinical interview, there needs to be a suicide and risk assessment. So this is risk of harm to the client and risk of harm to others. Then you have the treatment plan. I talked about this a little earlier. Typically in a treatment plan, the format, the framework is given to you by an agency, although a treatment plan can be written as a narrative, from a blank Word document, for instance, and just typed out. But oftentimes it's a table, and it has objectives. And these objectives, typically there's 3 or more. These objectives lead to a goal. Right? So a goal has, say, 3 objectives or 4 objectives. So the objectives always point toward a goal. And then there are interventions for each of these objectives. And that's these are counseling interventions, typically. Again, for some goals, you may rely on other resources. So if one of the client's goals is to, as I mentioned earlier, find housing, the intervention may be to refer that individual to an agency that assists with finding housing. And then you have your recommendations. This is the type, duration, and frequency of treatment. Usually this would be individual and or group therapy. Sometimes you may recommend that a client consult with a psychiatrist. Family therapy can also be indicated. And as I mentioned before in the treatment planning, referrals to other providers. This would be an area where you may want to mention any referrals that were indicated during the clinical interview. I want to thank you for watching this video. I hope that my explanation of clinical interviewing was helpful to you. As always, if you have any questions or concerns, feel free to contact me, and I'll be happy to assist you.